68-year-old male Caucasian with a previous PTCA and stenting for a myocardial infarction in 2012. The patient, since 2013, has an asymptomatic chronic anemia. During the last 6 months, the patient started to complain of heartburn, epigastric pain, regurgitation, but no dysphagia. During the last 4 months, the patient also started to present with melena. No fever, nausea, vomiting, or weight loss were reported. In February of the current year, the patient underwent an upper endoscopy which showed the presence of an ulcerated lesion of the distal esophagus which was extending 10 centimeters in the subcardial region and was bleeding at instrument passage. We are still waiting for the final histological report. The patient in March underwent a CT scan which revealed the presence of multiple small mediastinal lymph nodes, 2 small aspecific nodules at the right lung in the upper and lower lobes. Also, a bulky heteroplastic lesion of the distal esophagus which was involving the cardiac and part of the lesser gastric curvature. The CT also reported multiple surrounding lymph nodes. At the abdominal level, there was a 7 centimeter lesion of the 7th hepatic segment which was suspicious for metastasis. No other abdominal or pathological lymph nodes were reported. The patient underwent a PET scan revealing a hypermetabolic lesion of the distal esophagus and cardiac. There are no other evidences of pathological findings. Blood cancer markers are negative, and the patient is now scheduled today for a staging by endoscopy prior to surgery. The procedure will be performed by Dr. Giovannini and Dr. Depre.
First of all, I want to explain the scope that I use. If you can focus on the scope, this is the new EUROEUS scope from Pentax. It's the slim scope. It's a 10.8 millimeter diameter. It's like a gastroscope, and I use this scope in this case because you see on the endoscopy image, I don't know if you have the endoscopy image, there is a stenosis in the esophagus, and the goal is to pass through this stenosis using this slim endoscope. If I fail to pass the other solution, there will be 2 solutions. The first is to use the EUROEUS scope because it's thinner, it's a 6 millimeter diameter scope to reach the cardiac area. And the other option, if you don't have the EUROEUS scope, is to pass with a gastroscope, to leave a wire inside and to pass this slim scope on the wire. Okay,
so you don't dilate anymore.
No.
Okay, so I think that's
no. If I don't pass, the other option is to do the staging of the upper part of the lesion to check if there is a distant lymph node in the cervical area, and after the patient should be treated by a preoperative radiochemo because it's an advanced cancer on the
so
CT,
usually
and you
at
can
least
do
a T3. Yes.
Another EUROEUS to stage the distant lymph node in the susmesocolic area after the radiochemo. Yeah. Okay, now I will try to pass. I will use the endoscopy image. If you have the endoscopy image, you see the lesion, and I will try to pass gentle inside the lesion here. You see, and you see that this scope is it's a very nice scope because now I'm into the stomach, and you see I pass easily. I use a small trick. I don't know if you see my balloon is a little bit inflated, and this gave us the security. It's less traumatic, and I used the balloon little bit inflated like an airbag, and this facilitates the passage of the scope because the balloon inflate will take the form of the stenosis, and this is quite useful. Okay, now in this case there is a suspicion of liver metastasis, and I will start the examination in the bulbus because habitually I start always in the bulbus for the gastric cancer because to see if there is some prepyloric node, which is considered as N2.
So that means that you focus on search for distant lymph nodes and metastasis rather than focusing on the T staging.
Yes, because the T staging, I know this lesion is a T3 and 1 because on the CT and the endoscopy aspect is circular. And now the goal of the US is to find some contraindication to surgery. or in case of course, limited lesion on the CTs, to try to find indication for neoadjuvant radiochemotherapy. Okay.
I noticed there are many places where they don't use balloons anymore because balloons are expensive. Do you use a balloon systematically or not?
Yes, my hospital is rich.
Yeah.
But I can understand. Okay, here you see this is the gallbladder. This is the liver. The right lobe is not easy to assess. I inflate my balloon here. This is the sushepatic vein.
You see the ball is at the right of the scope, so tip of the scope is there.
Yes, this is the hilum.
All this, yeah.
And yeah, I don't see the lesion, but a 7 centimeter lesion should be biopsy should be done by the percutaneous way.
And do you change the settings for the liver examination? Do you go for harmonic imaging or other types of imaging?
I use the harmonic imaging all the time.
Okay, so it's...
Okay, now here you have the celiac trunk and the supramesenteric vein. Yes, with the pancreas. This is the body of the pancreas with the pancreatic duct. It's very important also to check the pancreas during gastric cancer to be sure that there is no infiltration of the pancreatic tissue, because the tumor should be classified as a T4. And also to see if there is a small amount of ascites. Here is not the case. Huh?
No.
Okay, here I don't see... this is the left lobe. Again, I try to check the left lobe to be sure that there is could be something, small vessel we can increase.
Yeah.
Here there is a small lesion here. It's difficult to be sure. It's too small for USFNA. Okay. Okay. Here there is no. I will go now at the level of the cardiac junction.
Yeah.
Here you see, this is the aorta, celiac trunk, and you see what is important. There is no node here. Huh? There is no node. There is no node in the celiac area. This is the tail of the pancreas, the body of the pancreas, sorry. Now if I do a clockwise rotation, spleen. This is the spleen.
Spleen, yeah.
There is no node in the hilum of the spleen also. It is mainly this lesion is more... what is this? It's a part of the pancreas or it's nodes? Oh. This could be nodes. No, it's nodes. Here, yeah.
Would you like elastography?
If you want, yes. Yes. It seems a malignant node in the hilum of the spleen. This is a N2 lesion in the classification. Okay, perfect. Okay, now I move to see the lower part of the lesion, and this is the stomach. This is the small curvature of the stomach here. I pull back my scope. I'm sorry, I lose a little bit the image. So
for any cardiac tumor, you have, of course, to be very precise on the extension, on the gastric side, and on the esophagus.
Yes, because this changed. Here you see you have an infiltration of the... I inflate my balloon, but you see here the beginning of the lesion, which seems like a linitis.
Yes.
If you can increase the image like this, and you will see here, if you can freeze the image here. Okay. Yes. Here you see very well this infiltration. This is the muscularis, and we are just at the level of the junction between the infiltration, the normal wall, and this infiltration here. This seems more like linitis infiltration of cell ring cancer. And now here I'm at 40 centimeters of the dental arch. I think this is very important to know. And also to see if for the surgeon, if the cruise of the diaphragm is involved. Here we have the lesion.
That's going.
Yes, in the
muscle.
Yes,
here.
in the muscle here. This is a T3 lesion here, definitively. Here we have this infiltration, huge infiltration with nodes.
Yeah, nodes.
Here. Now this is a T3 for sure. But it's important to know if there is a infiltration of the cruise of the diaphragm, because this is a T4 lesion, and this is it's very difficult for the surgeon for the resection. And here it's not easy to see, because I should see I think it's probably here, yes, but it seems free here. Huh? It seems free.
Yeah.
Okay, the lesion is a little bit higher. Okay, here we are into the esophagus. We are at 35 centimeters.
And how do you make a difference between a T3 and a T4 here?
I think it's not so different. It's not easy. But for example, a T4, if there is a pleural infiltration, is not a contraindication for surgery. This is the spine, I think, or
Spine,
it's
yes.
spine. Huh?
Yeah, spine.
Okay. I will try to
But it looked like a circumferential lesion. So how can you manage then with a linear scope?
I do the turn like this. You see, I do. I start at the level here. This is the aorta, and I do a complete turn to see again the aorta like this.
And you do it at every level.
Yes.
You are about 35 centimeters there.
Yes. Now I remove again the scope. Here you see there is a lot of nodes here.
Again, yeah.
But these nodes are peritumoral nodes.
Yes.
Okay, I do here again another node here.
Carina here?
Yes, this is the carina. Yes. Here you have the left atrium with a small node. This is the pulmonary artery, and you see that there is tumoral infiltration again here.
With nodes.
And there is node here.
Yes, sorry.
This is very deep.
Yeah.
But now what is important is to know if there is a node in the cervical, in the upper part of the esophagus, so-called after this is the Mickey Mouse area.
Can you explain us area 4 and 5 in this?
Yes, this is the arch of the aorta and the pulmonary artery. And just at this level, you have the arteriosus, what is the canal? It was the old embryologic junction between the pulmonary artery and the arch of the aorta. But if we have node now after the arch of the aorta, up to the arch of the aorta to the cervical area, these nodes it's very difficult for the surgeon to do the dissection of these nodes. Okay. They need a free, a third access, the cervical access. And in this case, the patient should be discussed for a medical treatment, only for a radiochemotherapy. Yeah. I think that now the most important part of the examination starts now, and is to see if there is node in this area.
Well, the liver is very important.
The liver, yes, of course. The liver should be punctured on the CT or on the US percutaneously. But for cardiac junction, here you have the internal carotid, the left internal carotid, and this is the lung, the apex, the left apex. Here you have this is the carotid and the subclavian artery, and here the carotid and the jugular vein. And this is the cervical area. Now I will do a turn. Thyroid, yes, we saw the thyroid. And there is something here. Now, this is very, very important. And this node should be punctured. Even if he has central classification. Maybe it's inflammatory. Maybe.
So that's classification. You think it's a central vessel?
Could be, but it's not in the. If you should. Yes. Thank you very much.
Sorry. Yes, I'll let you do. Because I'm concentrated on the. Yeah.
It's very difficult to know if there is a vessel. No, I will prefer to do this. And here you see that is not in the center completely.
No, right.
It's not in the center. It's a little bit in the periphery, but this is a node. This node should be punctured definitively, because if this node is positive, this patient should be considered, for me, as a very bad candidate for surgery.
Okay. Yes.
Okay.
And which needle would you use for this?
I think the 25. Just cytology is enough.
25.
Because 25 will be okay. Huh?
Yeah, because the size is.
A size is less than 1 centimeter, for sure. But you see, the calcification is, when this hyperechoic is not in the center. This could be, what I said, compressed by some malignant, it's 8 millimeter. Okay, we will go back, yes, sorry. And now I need a needle, please.
The 25 gauge.
And I need somebody to help me to maintain the scope in a good position, because
I will maybe change my position.
You see.
Yeah, I have to feel it. Okay, yeah.
Voilà. Okay, like this is perfect. I block my wheel.
Mark, this was an excellent explanation of the anatomy.
Okay,
Perfect.
now I will perform the biopsy, and we will wait the results. I hope to be quick. Okay, you see the needle. The needle is inside. Okay, you can remove everything. No, give me the aspiration.
I'm concentrated to help Mark. That's usually what we do with the fellows. Keep the scope.
You see the needle is in the center of the node. You give me the syringe, please. Okay.
So you see also the quick movement Mark is doing when he punctures those small lesions. Quick movement, even if you go through the node, not important. And you can usually feel the passage through the node capsule.
You see now I move a little bit the needle with my elevator. Okay.
And usually sensitivity for malignant small lymph nodes is usually very good, especially with adenocarcinoma.
Here I don't know. It's soft, but not so soft like inflammatory nodes. But I think here it's very important to. Because only the US can show this kind of small nodes, but the prognosis of the patient is it's very important, because if you operate the patient and if you leave a malignant small node like this, the patient will recur after 3 months after the surgery.